Hello, my name is Dr. Carl Michel. I'm a practicing foot and ankle surgeon at Genesis Foot and Ankle Institute, as well as board member of T. Lee Ward Jefferson Medical Society, where I currently serve as parliamentarian, health fair, and health education chair. T. Lee Ward Jefferson is made of healthcare professionals dedicated to improving the health and wellness, access to care, academic and career opportunities and the quality of life of our underserved populations through the provision of healthcare, education, career exposures, and youth development services. Thank you for electing to take this opportunity to learn. We hope you find this offering valuable in your everyday life. If you would like more information on T. Lee Ward Jefferson Medical Society, please visit our website at tljmedicalsociety.org.
Next, in our series on opioid education, the Pharmacist, More Than Counting Pills.
Count by 5, then throw pills from a big bottle to a small bottle.
Their new role in spotting an opioid problem.
We're responsible for watching what the prescribers do. A lot of prescribers are educated in their craft, but when it comes to medication and what it does to the body, that's when we step in.
But first, red flags at the dentist.
Patients typically would come in and they're already anticipating that you're going to give them some type of opioid. And it's crazy because you're like, oh my gosh, no, you don't need it.
How education can break down stereotypes.
Because I want to make sure that I can hopefully help them think differently than what they're used to hearing from usually from their friends.
And advice to our colleagues.
If we can just take a pause before we hit that send button and realize that, this is a real person. This could be our mother.
So we have to be more accountable and not feel intimidated into doing things that could put someone else in danger.
I'm Sandy Collier, and thank you all for being here with us this evening. Joining me is Dr. Flora Bensian-Chill. Dr. Bensian-Chill, thank you so much for being here. Why don't you start by telling us a little bit about yourself and your practice?
Oh, most certainly. Thank you for having me here, Sandy. Yes, so I actually am originally from Ghana, West Africa. Came to the U.S. about 30 years ago. And we moved to Florida after I finished dental school. And I worked in Fort Myers for a little bit, but then my husband's job brought us over to this side of Florida. And just about a year ago, I opened a dental office in Delray, West Delray specifically. And we focus on just helping patients feel more relaxed at the dental office. I like to say I kind of went into dentistry naive about the fact that patients hate going to the dentist. I was not aware of that, to be honest with you.
I'm one of those patients who hates going to the dentist.
So, when I graduated school about 10 years ago, I said, this is great, let's start a business, blah, blah, blah. And then I hear people saying, oh, I hate the dentist. And then I saw the statistics about how people would rather go get I don't know what they would get instead of going to the dentist. And I thought, what? Really? So after working in different places, I did public health, I did private practice, and then decided, okay, let me do my own. Because after seeing all those aspects, there were different things that I wanted to incorporate into my own office. And one of the biggest things was a relaxing atmosphere. So we have a very spa-like office where patients, when they come in, we have, aromatherapy going on, we have headphones, we have pillows, we have blankets, we also have like I said, just oil therapy to just kind of help them relax. And we have, of course, Netflix. Netflix is everywhere.
Absolutely.
So they get to watch and chill and do whatever they need to do while we beautify their smile for them.
Wonderful. So making the dental experience a lot more pleasant.
Yes, our slogan is, it's time to love your dentist.
Okay. All right. I think I'm going to have to come and see you.
Certainly.
Let's move right on to our topic tonight. Can you speak to us about your experience with working with low-income patients in Palm Beach County?
Yes, I had the pleasure of working for about 2 years with Healthcare District of Palm Beach County, and they have an amazing program for patients who are either underinsured or just low-income populations that don't qualify for different programs. And it was a great experience working with them and trying to educate them on, just their oral health care needs and different things like that.
What was the biggest problem that you saw when working with the population?
Honestly, neglect, whether intentional neglect or really sometimes unintentional. Especially patients who come in with their kids, kids with mouthful of decay, cavity infections, and for, like I said, most of the time you could tell for lack of education, or sometimes the parents were very busy. Sometimes they have two, three jobs, so time to really spend to nurture their child's oral health was difficult, and even for them themselves. Sometimes they'll say, "Oh, you think you see that with my child?" It's like, "Oh, you don't want me in your chair," and I'm like, "No. Let's talk about it. Let's educate. I wanted to work on educating them so that the child could see what needed to be done and when they started doing changes, that helped, foster that change in their kids as well. Because sometimes also with teenagers, it wasn't just their 4 or 5-year-old. 4 or 5-year-old is different in what they can do. But a teenager, when they start seeing their parents make some changes and their parents reinforcing that, it makes a huge difference because emergency room visits for kids and adults, alike for oral health it's incredible. It's not just a cost, but the amount, the number of people who overwhelm the system, the hospital system or the urgent care system with toothache. And sadly, when they go, there's not much the hospitals can do for them or the urgent care can do for them. Sometimes if they're lucky, they may give them antibiotics and say, okay, go find a dentist. So
you have to get back to the dentist anyway.
Exactly.
So what dental procedures would usually require the use of pain medications post-operative?
Oh, quite a few, but mostly extractions. Okay, and then when we talk about extractions, we have two main types of extractions. We have what we call routine extractions, and then we have what are called surgical extractions. Routine, most of the time the tooth is already kind of loose, or it doesn't take much to get it out. So those usually we don't anticipate a lot of pain from them, but everybody's pain threshold is different. And then with surgical extractions, that's where we may have to, make some space around the tooth to be able to get the tooth out. May mean like moving the gum away from the tooth a bit and then maybe removing some bone from the tooth or maybe even sectioning the tooth to take it out piece by piece.
What are some strategies you use to ensure your patients are given the best care in order to limit their risk of opioid addiction?
Well, it always starts with, obviously trying to be as gentle as you can. They say physician do no harm. Just trying to be as gentle as you can in the procedure. But, sometimes situations change where it's like, okay, this tooth is really not, corresponding to just regular simple methods. So we may have to be a little bit more aggressive with the treatment. So in that regards, whilst we're going through the process, we usually talk before because you usually can kind of anticipate whether it's going to be a simple routine extraction or a surgical extraction. So even before we start the procedure, we always talk to the patients and say, okay, listen, this is what, these are some of the things to expect and this is what we're going to do, based on what the outcome is. And so, I usually like to tell patients, listen, opioids, especially now, opioid is such a huge issue in the whole country, especially in the state of Florida. So, I always like to tell patients, listen, opioid is not, narcotics is not something that I like to give as a first line of drug for my patients after surgery. I mean, sometimes, like I said, we do some very invasive surgery. Sometimes it may be where we have to remove some bone for different contouring procedures. And so, patients typically would come in and they're already anticipating that you're going to give them some type of opioid. And it's crazy because you're like, oh my gosh, like, no, you don't need it. But that's like the mentality patients have now because it's like, oh yeah, I went to the dentist, I had such and such, and they gave me Vicodin or they gave me Percocet. And so sometimes they even come in with that language, which, to be honest, sometimes if you go to your dentist and use that kind of language, it raises a red flag. I'm just going to tell you that because, it's like,
Absolutely.
okay, it raises a red flag because that's not really the normal day-to-day pain reliever. But anyway, so going back to, doing a procedure and helping patients, anticipate what to expect and what not to expect, I like to tell them, listen, we have different pain receptors in our body. One of the researchers, or actually many researches that have been done, shows us that there are pain meds called NSAIDs, or non-steroidal anti-inflammatory medicines. What they do, it's like things like ibuprofen, naproxen, like Aleve, Advil. Those things, or Motrin, those things help relieve inflammation. Basically, they help reduce swelling. So that's very, very, very important.
So those are alternative medications that...
Exactly. Those are alternative medications for to relieve pain. And those things have been found to be very effective, like extremely effective. And then, you have other pain medicines like Tylenol, acetaminophen, and that works on a different type of pain receptor. So what research has found that giving patients those medicines in alternating, usually I'll say, okay, take a Motrin at noon, and then at 4 p.m. take a Tylenol, and then at 8 p.m. take a Motrin, and then at midnight take a Tylenol. Basically alternating like every 4 hours or so makes amazing difference in pain relief for patients.
So this rolls right into our next question, doctor, about the importance of patient education when it comes to the management of their own pain.
Yes, I am a firm believer in that. I really believe in spending that time to educate my patients before we even do anything, because I want to make sure that I can hopefully help them think differently than what they're used to hearing from usually from their friends. The friend may say, oh, I went to, the doctor, the dentist, and they did X, Y, Z. I remember for me, I had my wisdom teeth extracted when I was 17 years old, and the oral surgeon sent me home with Vicodin, and I ended up, I just had terrible nausea from it. After the first day, I couldn't take it anymore. So I think my mom just ended up giving me Tylenol or what have you, and I was fine. But when patients, unfortunately, sometimes as physicians, we want to just not have to worry about the patient having any pain. So it's like, let's just give them this thing, let's just give them this, narcotic, because, honestly, it's easier for us. We don't have to worry about, well, what if they still have pain? It's like a guarantee. But, obviously now we're starting to realize that's not necessarily the best thing, to just throw that opioid or that narcotic at the patient, because it actually ends up causing more harm than good. And surprisingly, Sandy, they've actually been doing research that they find now that opioid is not necessarily the best pain reliever for some patients. Like, the results they get from that is not that much different or greater than they would get from an over-the-counter like Motrin, Aleve, Advil, or Tylenol.
In terms of pain?
In terms of pain, exactly.
It just has an addictive factor.
Yes.
So, doctor, let's talk about some of the challenges you faced when dealing with patients who lacked access to care, like our homeless population.
Well, so one of the things, interesting enough, we have such a diverse population here in South Florida. And so language barrier was actually a huge thing we had to work with. But thankfully, the Palm Beach County Health District, they work with lots of different translators. So sometimes we'd have to use a tablet to, get a translator involved, in talking to them, or maybe even sometimes the team members, you may have a Creole speaker or a Spanish speaker and things like that. So really sometimes just the basic form of just communicating information to the patient in terms of, okay, this is what's going on, how can I help you? And then getting the patient to be free to speak to you, because sometimes they don't even know what to tell you or really how to explain to you what they're feeling, because to them the normal things that you and I may say, okay, no, this is not right, to them like, oh, I've always dealt with this, I didn't think there was anything wrong with it. So just really trying to understand them from their language perspective or from what they've seen. I'm just trying to educate them and talk to them and hearing them. Sometimes you just want somebody to listen to them, and so thankfully we had sometimes had that flexibility and time to be able to listen to them and educate them, like, hey, you know what, let's work on your mouth this way, or here's a toothbrush, this is how you should hold the toothbrush, this is how you should use it, here's some floss, this is how you should use it, and things like that.
What steps did you take to ensure that the patients you were seeing were not addicted to opioids?
Really just, like I said, just talking to them, asking questions and making sure that they didn't feel afraid, because, honestly, some of the patients we would have, they have a history. Sometimes, homeless people have, there's sometimes, not always, but there's sometimes a history as to how and why they're in their situation. And, we would meet a lot of them that, are in their situation because of drug, abuse in the past, So just, trying to let them feel comfortable, to be open to talk to us. And then, just saying, hey, you know what? Okay, now let's move on from here. Let's talk about different types of medicines that you can take that it's okay. And some of them, they already knew. They're like, hey, doc, listen, I can't get an opioid or whatever. And guess what? The healthcare district, we didn't even give opioids. That we just decided that was not an option because we just wanted to make it a clean slate for everybody. We didn't want to discriminate. We didn't, because you really can't determine by looking at somebody whether they have a drug dependency issue or they have a potential for it. So at the healthcare district, we didn't do that. Now at my office at Flora Dental, what we do is a little bit different. We do talk to patients to make sure that, hey, sometimes opioid may be a necessity. We understand and respect that, but we make sure they know that that's not a first-line drug therapy that we're going to give them based on whether we're doing extractions or we're doing implants or we're making prosthesis of whatever it is that we're doing, root canals. We make sure they know that we understand that can come with some, discomfort, some pain, but letting them know that there are always other options that we can talk about, that we can give them to reduce the pain, and it does not always have to be an opioid.
So, doctor, let's talk about how pain management in dentistry has changed over the years.
Well, there has been some advancement. I have to say that we there has been some advancement, some changes. I think as the medical professional in general started realizing how bad and how severe opioid usage was, we all kind of tried to start doing things differently. And in the beginning, actually, in some research that I was doing in preparation for this discussion, I realized that most people really didn't think about the dentist as potential source of opioid abuse in patients. And that's when they started realizing that, wow, patients, is like I said, in my experience at 17, I went to get my wisdom teeth taken out and I was given an opioid. And then now they're starting to realize that, oh my gosh, like sometimes that's where it starts in some of these teenagers and these young adults. So they go to the dentist and then for an extraction for, different reasons, and then they're given an opioid and then like, wow, this makes me feel such and such way.
So you've been very mindful of that.
Exactly. Yes. We're trying to be very mindful of that to make sure that, okay, let's do things differently. So the other thing too that, has been developed or adopted nationwide, especially here in Florida, is a program called eForce, where we're all really honestly mandated to look up patients' history before any narcotic is prescribed. There's a program that every healthcare professional has access to look up every patient. We have your date of birth, your address, what have you. We take that information, log into the website, and honestly, we have to look up a patient. Before we prescribe a narcotic, we have to look up the patient, see their history, because it's all documented, see their history of narcotic usage, see, okay, when was the last time they were given narcotics? What were they given it for? Are they in pain management treatment right now for whatever reason? Because sometimes you do have that. Patient is going through pain management treatment. They end up having to be on different medications. They become addicted to the pain management. And then before you know it, I recently had a patient who, I was the third dentist they had seen that day.
Wow. That day?
That day.
Oh my goodness. And how did you find out that you were the third dentist?
I went into eForce, I looked at them up and I thought, well, it looks like they recently just got a prescription. So I called the pharmacy actually that they were recommending I called the prescription into. And the sad thing is this patient wasn't even aware that we kind of track them, I suppose. So, I called the pharmacy and I said, hey, wait a minute, like I'm seeing on here that this person is here with me today saying that the dentist they went to, couldn't pull their tooth because they were, but so now they're coming to me because they hear that I can pull their tooth for them. And so they want me to take it out for them the same day. And I said, okay, well, let's wait, let's see. So I did the X-ray, I did the evaluation. I realized that, okay, there's a lot of infection here. I said, that's probably why the treatment didn't happen with that dentist, earlier in that day. So I said, looks like you need to be on some antibiotics first, and then we'll bring you back in a couple of days, get things to calm down. I give them some therapy. So one of the things I love actually is clove oil. Clove oil is excellent, by the way, as a temporary method to rub around your gums if you're having tooth pain and you can't see a dentist right away. So anyway, I said, okay, let's do some of that for now, and then, go from there. He said, oh, yes, but doctor, what about my pain medicine? I need some Vicodin or Percocet. And I said, well, you know what? I understand where you're coming from, but, based on what I see a lot of infection, so antibiotics would definitely be a first line. Because for some patients, really, when you get that abscess, when you get that infection, it's trying to get itself out. It's trying to relieve itself. So the antibiotics, really, is what's going to help start relieving the pain. Sometimes you hear them say they're taking all kinds of pain meds, it's still not helping. Well, yeah, sometimes because you need that antibiotic. So for this patient in particular, we started talking about that. They were being very adamant about the Vicodin because I said, okay, 1 second. I looked him up, and then I noticed they already went to another dentist that day. And actually, did they get a prescription? And of course, they got a prescription for a narcotic. And so I got off the phone, I got off the computer, and I went to him and said, hey, listen, I noticed that I'm not the first. He said, well, I told you, you're not the first dentist I've been to. I said, yeah, but you're asking me for more narcotics when that dentist gave it to you. Well, how did you know that person got in it? And I said, well, guess what? There's a drug monitoring program now that the state of Florida has adopted, and it's really to protect you. Because sometimes patients don't understand that. It's not to be like,
the police.
To be a police. It's really to protect you.
Right.
So I said, I'm sorry, but unfortunately I can't prescribe you any more narcotics because you already have some that you picked up this morning. I spoke to the pharmacist.
So, doctor, if you had the power to make any change in the fight against opioids, what would that be?
Good question. I would say one of the things that I would love, honestly, to see my colleagues and I do more of is follow-up care with our patients, calling them. I thankfully now have the luxury of calling my patients at the end of procedures, at the end of the day, or maybe even the next day and saying, hey, how's it going? Just calling to see how well you're doing. And sometimes even just that word in, patients like, oh, yeah, actually, I'm not really doing that bad. I'm okay. Sometimes just that word and just letting them know that we care. And then also not being so quick to throw out, I hate to use the word throw out, but honestly, that's how I see it. To just give that patient that prescription for the Vicodin, for the Percocet, things like that. Just being mindful that, listen, like now there's more research now that shows us that something as simple as an over-the-counter medicine like Tylenol and Aleve or Motrin can really can make a huge difference in pain management for patients. So if that really could kind of make that change, maybe impress it out on some of my colleagues, so that, because it starts with us. If we can believe in that type of medicine to help alleviate pain, we can educate our patients to believe that as well, and not just believe in that old mindset of, opioid is what's needed to relieve pain. Because sometimes I think as we start to realize, it's the mind, it's what we perceive, it's what we expect. When a patient comes in the office and the first thing they're saying is, doc, I'm in pain, can you give me a prescription for something? And they're like, I've taken, Tylenol, it didn't do anything for me. And then I say, okay, well, let's take it in a different way. Let's add something else to it. Let's not just jump to our narcotic, because honestly, sometimes it's easy to give the patient that because it gets them out of your chair, out of your room, your hair, so to speak, so you can move on to somebody else. But I really wish I could kind of impress upon our colleagues and really make them myself, for us to spend more time with our patients and educating them that, hey, listen, there is a different way.
So when you start to write that prescription, think in the back of your mind, am I helping this patient, or am I hurting them further down the road?
Exactly. And even their family, the rest of their family, because, now we realize it's a systemic issue. Sometimes they finish with the medicine, they don't dispose of it properly, it can get in the wrong hands and things like that. So yes, writing that prescription, well, now, it's all on the computer, just very easy, to just hit the send button, but if we can just take a pause before we hit that send button and realize that, this is a real person, this could be our mother, our child, our sister, our brother, that could end up down the wrong road based on what we gave them, honestly.
So, doctor, we have a lot of medical professionals listening to us this evening. What advice do you have for them as we close out?
So, honestly, spending that time, even if it's just an extra minute or two, talking to the patient and letting them know. And if you don't have the time, I notice that, sometimes some patients, they'll listen to my hygienist or my dental assistant. I'm sure for you, they'll listen to your MAs, while they're taking their blood pressure or what have you. Like, hey, you know what, yes, you may experience some pain or discomfort after this, but know that we really do have the best, your best interest in mind. And so, let's try a different type of pain modality. And also just checking up on the patients. These days, everybody loves to be on their cell phone. So, and I just send a simple text. Hey, just check, this is Dr. Flores, just checking to see how well you're doing. And you don't even have to be the one to send that text message. You can have somebody designated in your office to send that text message. But I see it goes a long way to letting our patients, especially patients in our community, in our practice, it helps them know that we care, and it also grows their practice.
Doctor, thank you so much for being here with us this evening. We had a wonderful conversation. I learned a lot from you. I'm Sandy Collier. We'll see you again next time. I'm Sandy Collier, and thank you all for joining us this evening. With me is Dr. Keaton Grant. Dr. Grant, thank you so much for being here.
Thank you for
and
having
you're
me.
a pharmacist.
Yes.
Why don't you start by telling us a little bit about yourself and what you do?
Hello. So I am a clinical pharmacist right now. I work for the Baptist Health System. My job entails antimicrobial stewardship, pain management, and all platforms when it comes to like healthcare. As we speak, my main focus right now is the opioid crisis is a big factor when it comes to hospital pharmacy, because we have a lot of patients that are post-operative. They just had like surgeries, and this is the first time they're being introduced to opioids and medications of that class.
So, can you tell us a little bit about the history of how the opioid epidemic started, in your opinion, and how has it progressed over the years?
The opioid epidemic started inside the health system, which is very unusual. Most drug epidemics start on the streets. So what happens is a lot of patients, they get introduced to these medications for a legitimate reason, whether it be a car accident or post-operatively. And after they run out of their medication, the ones that do develop an addiction or dependency on it, which is two different things, there's addiction and dependency, they seek these medications afterwards, whether it be on the street or continuously shop around at different doctor's offices to get access to them.
Explain the difference between dependency and addiction.
Dependency is defined as your body believes you need the substance to function and do regular tasks, whether it be going to work, having a conversation with family, going out for a walk. You believe that you really need the substance. So your brain really becomes dependent on this. Addiction is more as the behavior that stems from dependency, where you go above and beyond just to get access to these products.
What is the role of a pharmacist in the healthcare delivery? And how does that pharmacist serve as an asset in providing healthcare to the community?
So the role of a pharmacist is the final check and the final decision before any medication or care is given to a patient. We're responsible for watching what the prescribers do. A lot of prescribers are educated in their craft, but when it comes to medication and what it does to the body, that's when we step in. And we have to make sure that we let them know when something doesn't seem right, or this might not be the right choice for this specific patient based off what we see on lab results and everything else that has to do with the patient.
As a pharmacist, how has the laws changed over the years?
We transitioned a lot into the clinical aspect of things. So we transitioned from being regular pharmacists that push pills that everyone know about, that count by fives and throw pills from a big bottle to a small bottle, to the clinical aspect where medications have grown over the years. It went from probably back in the 80s, a couple hundred pills to 300,000 different types of medications on the market with different adverse reactions and drug-drug interactions and different risks that we have to consider. So they had to come up with the PharmD, the doctor of pharmacy, people that study these medications extensively to assist the nurse practitioners and all the physicians and every provider in using them.
So let's talk about the importance of the relationship between the pharmacist and the physician, and why is it so important as it relates to opioids?
The importance between the pharmacist and the physician and opioids or any medication, it comes from a level of trust. The physicians and a lot of healthcare professionals, we don't really know what each other do. So you have to develop that relationship where they could know that you're coming to them and you're not kind of challenging their authority. They are the authority figure in the hospital systems. And you have to develop that relationship where they know that the information that you're giving them is evidence-based and not your assumptions or you're just trying to be the smartest, because it is a battle inside the health system of who's the smartest at all times. There's a lot of egos and things that you have to get around.
So what are some of the major changes that have been made over the past 20 years in order to improve the field of pharmacy?
There is now different specialties and residencies in place where pharmacists, other than getting a doctor's degree, you get additional training in different areas. There are pain management pharmacists, oncology pharmacists, infectious disease specialists. There are different levels that pharmacists can get to make sure that they're prepared to be a part of the healthcare team.
Let's talk about some red flags. What are some of the red flags that you look for as a pharmacist when filling opioid prescriptions for patients? And how can you tell if a patient is doctor shopping?
There's a pharmacy monitoring system that every state has. In Florida, we have eForce. You can see every doctor that a patient has been to specifically for controlled substances once you pull their names up. The doctors also log information in there. You can see how many pharmacies they visit per month for the same medication, if it was filled or not. Sometimes it gets a little bit more obvious than that. You get prescriptions from the same physician with the same handwriting from 4 to 5 patients within 1 hour. So you could tell that someone has sometimes they steal the doctor's prescription pad. And we've had issues with that. I've had to be a part of investigations when they're trying to follow drug rings, because a lot of things that happen now, sometimes there's fake prescription pads, or someone might call in pretending to be the doctor with a doctor's DEA number, but you could kind of tell that they're in character when they call. I've had situations when I was working in retail where the person that comes to pick up the medication has another person on the side of them coaching them and what to say to me at the counters if I can't hear them. So that it gets pretty obvious when we're dealing with red flags.
How do you handle that?
You have to be very sensitive with it. They are trying to pretend to be a patient that needs your help, and you can't just outright deny the help. You got to give them a reason. If I'm not going to fill the medication, I'm not going to fill this medication because you just picked this up last week. I can't fill it for you 2 times in 1 month. Is not safe, and it's not good for me as a provider to provide that to you. You have to give them a reason. You can't just say, no, I'm not going to do it. They'll go call your corporate offices at times because as per their character they're playing to get the drugs, because some are addicted. They're in need, and they'll go through any extent just to make sure that you have what they want and you're going to give it to them.
So if you suspect that a pharmacist, a doctor's prescription pad has been stolen, how do you handle that? What's the protocol to handle that?
Usually you could call the office and let them know that you've been getting a lot of medications consistently with the same pad. A lot of times they'll call us. Like, I'll get calls throughout the week from a provider, and they'll let me know, look, someone's been using my prescription pad. Be very careful. Give me a call before you fill anything under my name. There are providers that do that.
Wow. So let's move on to the next question. I got mesmerized by listening to that. What are some of the signs that you look for to determine if a patient is heading towards addictive behaviors?
I've seen with a lot of patients over the years, the first time they come to pick up like a Percocet or Vicodin, and as the months progress and they go from being treated for a car accident to long-term treatment of some chronic pain that they have, and their behaviors towards it change. It'll be someone you have a great relationship with in the community. As a community pharmacist, you develop friendships just like you're in a church or any community atmosphere. And the 1 month or a period of time where you might be out of the medication and they could no longer get it, you will watch that person's behavior towards you change right in front of your face. And then you realize that something's not right.
Is there a key difference between the effects of opioids versus over-the-counter pain medications?
Yeah. The only difference is opioids are addictive and they have like a euphoric feeling. For some people, not everyone, it makes you feel good when you take it. So, but for some people they get sick the first time they take it and never take it again. When it comes to pain management, opioids, according to clinical trials, are no better at managing pain than over-the-counter Tylenol. A lot of people, when they start taking opioids, they start at low doses, like let's say 5 milligrams of Percocet, and eventually they'll go tell their doctor, it's not working anymore, you need to up the dose. Clinical trials show that upping the dose of the opioid doesn't up the amount of pain it manages. It just makes you get high. So whenever they get used to or develop a tolerance to the dose they're taking and they no longer get the euphoric feeling, they think it doesn't work to manage the pain anymore.
Can you explain the concept of morphine equivalence and its implications in opioid prescriptions?
So morphine equivalent, so morphine is pretty much the original opioid other than, the street poppy seed and heroin from biblical times. So every opioid, they pretty much calculate the strength based on morphine milliequivalents. And each opioid, like fentanyl, has one of the highest grades of morphine milliequivalents versus oxycodone. The amount of morphine, or MME they call it, in each opioid kind of indicates the likelihood of causing overdose.
So describe how pain management is handled in the Black community by healthcare professionals.
So in the Black community, pain management is handled, I think a lot more skepticism is given towards Black people that do go out and seek high strength in opioids. You might see it in your families, or you could look in a study that's been done on it. We're at least likely to be given the optimum amount of pain management for most situations. But let's say in the hospitals, a lot of times we're seeing where Black women or anyone of color going to the hospital complaining of feeling pain, and there's a level of bias where some people believe that their tolerance for pain is higher. So you're at least likely to be given morphine and opioids in certain settings, to be honest. But right now, the opioid crisis is one of those drug pandemics that the reason it's a big deal is there's not one subgroup. It's not like the crack epidemic where it was one subgroup that gets targeted by it. This crisis affects the middle class, the wealthy. One of the things I did in pharmacy school, I worked with an organization called Generation RX. So before the opioid crisis went mainstream, that was an organization that was working towards the whole getting everyone aware about it. We actually made an organization here in Palm Beach Atlantic where some of the students went out and got media attention for it. And that was in 2017 when the opioid crisis was at its peak and more people died from overdose than any other disease or condition that year. So what we did see a lot when we did a Generation RX, we went to like an Opioid Anonymous meeting and we met with people that were battling addictions and different things happened to them in life. Most of the people that were dealing with addiction that we met weren't the typical people you think looks like drug addicts. It's not the stereotypical addicts that we see on TV. It's or moms and dads and regular people that have a lot of high-ranking jobs, people that are in stressful situations that end up losing everything because of addiction to Percocet or Vicodin. And that's why it's such a big deal right now to the government.
What role does the entertainment industry play in the influence of the use of opioids in the black community, in your opinion?
They play the biggest role.
Why is that?
It's mainly because we're least likely to get opioids from healthcare practitioners. So a lot of the opioids we get comes in the form of like cough syrups. You hear a lot. We have a song, Molly Percocet. Every rapper has a song speaking about the amount of codeine they put in their Sprite. That is a form of opioid. And that's the direction that we go into when it comes to opioid use that affects our community and our young people. A lot of influence rappers like Drake talking about using Xanax as a source of getting high and getting through the day. Adderall. You could, if you listen to the lyrics, especially when you understand, sometimes they use the brand or the manufacturer in their rap lyrics, right? When bragging about how much drugs they use.
So and the community hears that and they act on it, and
it affects the younger people. It affects the inner city areas a lot. Right now, most of the drugs that are being abused in those communities are pharmaceuticals because of that's what they're hearing, that's what the music says.
if you had the power to change anything in order to combat this opioid crisis, what would that be?
If I had the power to change anything in order to combat the opioid crisis, it would be for more providers to be proactive. Before giving a patient these medications the first time, actually do an evaluation. A lot of background needs to be given. Ask patient questions like, do you smoke cigarettes? Do you drink alcohol? Different things that could indicate an addictive personality can stop the patient that would go on to be addicted. Not everyone that gets opioids become addicts, but a lot of people that do become addicts have other addictive traits before even trying their first opioid medication.
I like to eat ice cream. You think I have an addictive personality?
It depends how dependent you are on the ice cream. If you needed to go to bed, then you probably shouldn't get any opioids.
So, doctor, on a serious note, we just talked about me being addicted to ice cream. Do we need to ask other questions beyond the standard, do you smoke, do you drink? Because most people probably won't admit that they're addicted to drugs or a narcotic. So as a doctor, do you have to be a detective? Let's talk about that.
I think there definitely needs to be more detective work done, especially when you look into the pain management clinics. There's a lot of those, and most of the medication they do prescribe are opioids. Maybe they need to have more involvement within the questionnaire and also have a psychological consult for the patient before taking them on to see if they are a candidate for opioids. A lot of people do show signs of being dependent on other products before even trying Vicodin or Percocet or any of those medications. They have a history of being addicted. It could be to video games, it could be to food or anything else like that. Everyone has their own vices or ways of dealing with personal trauma and life experiences, and that's what it really comes down to. A lot of these patients that do battle opioids and different things like that, it has a correlation between high stress lifestyles and different things they have to deal with on a daily basis, and this gives them a release. So if a detective work and a lot of effort is put into filtering these patients out from the beginning, it kind of reduces the amount of people that end up getting access to these medications in the first place.
So there is hope.
There is hope of handling it, and I think we've been doing a lot more on the technology aspect, having e-force in place, and there's also now limits on if a person gets an opioid for the first time, they only could get for up to 3 days in Florida. And if it goes above 3 days, it has to indicate the type of pain and a diagnosis code. Does this patient have cancer? Is the patient dealing with a recent injury from surgery? They have to be codes on there for us to look into. So it is getting better, but I would like to see more physician, mainly the one that have been practicing for a period of years, kind of integrate those into their practice.
So before we leave, we have a lot of your colleagues listening. What advice do you have for them?
My main advice to my colleagues would be not to feel pressured by the community to do things they don't believe is right or they don't feel right about. A lot of people believe like once they get a medication or a prescription, it needs to be filled because their doctor wrote it for them, which is inaccurate. Our job is patient safety, and when something happens, as we see more often than not, the people they come back to with the overdose of a family member or they just got into a car accident because of something we filled will be us, not their physician. So we have to be more accountable and not feel intimidated into doing things that could put someone else in danger.
Dr. Grant, thank you so much. I learned a lot. Thank you for everything that you're doing. I'm Sandy Collier. We'll see you again next time.
Coming up on our next episode, opioids in adolescence.
The adolescent brain, which still struggles with this idea of invincibility and being invulnerable and not having to worry about the consequences of one's actions, makes it extremely vulnerable when it comes to substance use.
And how a small change in the message may make a big difference.
So that's a really important thing, is being honest with people and telling them what can happen. Not just drugs are bad, not just if you use this you will die.
Well, thank all of you for joining us. Dr. Bensi and Chill is here with us, and we have a few questions for you, Dr. Bensi and Chill. So let's start with the first question. You mentioned the importance of patients to take more ownership of their pain management. What would you do if a patient is not competent enough to understand their own health or pain? How would you deal with that?
So then in that regards, I would make sure that, whoever their caregiver, that they, usually have with them, make sure that they're with them at that appointment and communicate with that caregiver. Make sure that that caregiver understands what I'm saying and what the needs for that patient based on the procedure we just did or the procedure we anticipate to do, what that would entail, and make sure that caregiver understands that, because typically if they may not be competent, sometimes they do have somebody that can help them understand that, and to make sure that we spend that extra time once again communicating, obviously, at this point, not just with the patient, but also with their caregiver or guardian or their parent or what have you. Yeah.
So, question for you, Dr. Bensi and Jill. Is it normal for youth under the age of 18 to be prescribed opioids after oral surgery? And how can you assess a child's pain tolerance to determine whether or not he or she should be prescribed opioids or not? That's kind of tricky, right? Let's talk
It
about that. It
definitely is. Yeah, it definitely is. So sometimes, I think I had mentioned sometimes with extractions, especially oral surgery extractions for wisdom teeth extractions. Sometimes that's where we notice it starts with the teenagers. And like I said, I had that experience myself personally. And did I need an opioid for that visit or for that procedure? Maybe not. Because, well, actually not. I did not use it. When I took it, I got sick, so I stopped, and I just, I just used ibuprofen or Tylenol or what have you. So they may not necessarily need that, but sometimes we may feel that that's what we have to give them because we've done a big surgery or what have you. So also, just as Dr. Grant had mentioned, there is a cap, on how many days supply we can give patients to make sure that that is being monitored. And then, so what was the second part of your question?
And the second part of that question was, how do you determine when it's okay to give a child opioids? Whether or not it's okay or not to give a child opioids, because it's such a difficult thing to determine, right?
It really is, communicating once again with their parents, in that situation with their parents in terms of, have they had any type of trauma in the past? How did they deal with that? And if there was any pain meds involved in that situation. And so once again, coming back to communicate, and then also just a few pills at a time if you feel like you absolutely must. I always say my first line, I don't like to do opioid as a first line. Talk to the patients and the parent or caregiver. Hey, let's start out with alternating with an NSAID and an acetaminophen with this. So they say, hey, I always ask, do you have Motrin or Aleve at home? Do you have Tylenol at home? If they say no, I said, okay, before we do this procedure, please make sure that you have some at home, so that once we do the procedure, you have a way of better helping this particular patient controlling the pain. So that, and then following up with them that day or the next day, that night or the next day, hey, how is the child doing with pain? And for us, dentistry, most of the time, all my patients leave with an ice pack. I say, hey, please make sure you put the ice on, because really a lot of times the pain is from swelling. So if we have them, at least starting out with an ice pack, starting out with something to help them kind of ease into it. And then what I wanted to add as well too is we tell them, stay ahead of the pain. When the numbing wears off, you're going to be in a lot of pain. So let's get some ibuprofen or Tylenol going before the numbing wears off. I say for the first 2 days, please don't try and be anybody's hero. Take the ibuprofen and Tylenol exactly the way that we have advised you to. That's very important, because once they do that, it makes a huge difference in the recovery process.
So, doctor, we have another question. We have quite a few questions coming in for you. And one of them is from a parent who says, what should I do if the doctor gives my child opioids and I don't want my child to have opioids? How do you handle that?
Don't, just say, okay, either talk to the healthcare professional about why you feel you don't want your child to be on it. And maybe if they still feel like, no, listen, they're going to be in a lot of pain. Okay, fine. I understand. As Dr. Grant has said, you can take the prescription, but you don't have to fill it. And I think that's very important too, that, parents and also patients are aware. You will, encounter the healthcare professional who really believes that opioid is the best thing. And, of course, that's their decision as a provider. If they feel that's best, then that's their decision. So, if you as a parent feel that, I think my child will be okay without an opioid, then assess that situation with your child, talk to your child and see how that goes, especially in the first few days, because that's usually when it's the toughest, kind of see how they go. And then you'll see that, yeah, it's fine, so, if you don't want to give it to them, like I said, there's alternatives there. There's, Tylenol, there's ibuprofen, there's Motrin, there's Aleve. Do that and move on with that. Yeah.
Yeah, so you don't have to fill a prescription if it's given to you. So you do have a choice. So we have another question for you. What training do dentists receive in school regarding medications?
Well, so we do take a course. We do take, a couple courses in pharmacy. I wish that we had more training in it, to be honest with you, but there's always continuing education courses that you can take. But the beauty about it is, as you start, talking with people, as you start, talking with other colleagues and even your patients, you start learning a lot of different things that you realize, okay, well, there is more to pain management than just, what we may have been trained in school. Because when we talk about doing root canals, when we talk about doing implants and extractions, that there's going to be some pain, and patients, like I said, patients come in there anticipating that pain. So yes, we're trained about it in school in terms of how to help the patient handle it. But, as you take more continuing education courses, because you have to,
as you take more and more of these courses, you start realizing, okay, I need to make sure that I can help the patient manage their pain in a different ways, not just opioids.
So, doctor, I got another question that just came in for you on that same topic that we're just talking about. What if I need, the question is, what if I need more opioids, but my dentist doesn't want to provide it to me? How do doctors determine pain level of patients and when it's okay to give them more opioids?
Well, that is a tough call. I will say so typically, if for me personally, if I have a patient that calls me maybe after the 3 days and says, "Hey, I still need more pain medicine," I always say, "Okay, you know what? I need to see you. I need to see you in my office. I need to see what's going on because maybe they've developed some type of abscess. You know, especially sometimes you kind of see that in our smokers. Unfortunately, maybe they started smoking right away. We always say, hey, no smoking for at least 48 hours. No drinking through a straw. You know, for a few days. You know, things like so. Maybe they've veered kind of off the path of the direction. You know, it happens. So I always say, I would like to see you in the office before I can really write you more prescription. I need to see you. And then we talk. Okay, what have you been doing? How has so I have them go through with me. Okay, what did you do day one? And then sometimes you start realizing, okay, they didn't follow through on everything that you may have discussed, and then we talk once again about the pain, alternatives. It's in the extreme rare after I've seen them that I'm like, okay, well, maybe we need to give you more. That even that, like I said, I would not do the highest level. Maybe I'll do like a tramadol or something, on a lower level narcotic before we go any further. But yeah, typically I would always say, I need to physically see you in my office because maybe sometimes I just put it on myself. Hey, maybe I need to take a look at, what I did. Maybe the sutures came out apart or what have you. Maybe the root canal, we may need to send you to a specialist to have that re-evaluated or what have you. Yeah.
Okay, so Dr. Bensi-Chill, I want you to sit for a second because I've got some questions for Dr. Grant, but then I have one more question for you. Dr.
Okay.
Grant, so are there any new pain medications that have been developed over the past few years that are less addictive than opioids?
Mostly everything outside of the opioid class that they had before are less addictive and equally as effective. In most clinical trials, when they run the effectiveness of opioids for pain management versus, let's say, ibuprofen, there's no real difference. So the whole thing with opioids and patients, usually they'll come in after their first time getting the medication and saying that it's not working anymore. Even increasing the dose from 5 to 10 milligrams doesn't increase pain management. All it does is increase the euphoric feeling. So usually one of the biggest signs that someone developing a habit is when they want the dose to increase. They say it's not working anymore. That just means they're not getting high anymore.
So I have another question for you, Dr. Grant. Have you seen any improvements in the field of medicine as it pertains to the perception of pain tolerance in Black and Brown people? Let's talk about that a little bit.
I haven't really seen much improvements. I actually switched my job recently. One of the worst parts of retail pharmacy is being the person that have to tell them no, being that last line of defense after they get the prescription from their provider, because their mindset is going to be, my doctor wrote this. Who are you to tell me that I can't have it? Right. But at the end of the day, we have like, we're all going to be liable for whatever happens when they leave the facility. I've had situations where someone might have left, went on the road right after picking up their medication, family member come back in, or this person overdosed a couple weeks later, or this person took the medication in the parking lot and crashed. So I feel like for the most part, there haven't been much improvement. I'm not seeing dentists writing for more than a 3 or 7 day supply. I don't think the issue is coming from the dental industry or that entire healthcare practice. I don't really see them causing much of an issue with it. But other than that, for the regular physician, sometimes you see podiatrists write for oxycodone, which shouldn't really happen.
Wow. So another question, and I've got this question for you, Dr. Flora. So a person comes into you and they're obviously struggling with an addiction and they need dental work. How do you deal with that? What would the conversation be like for that patient for them to feel comfortable in getting work done through you?
So, we actually have quite a few patients that we currently treat. We're currently treating in that situation. So, I know I keep saying the same thing, communication, but it really does, it does play a big role in that. So, so when I meet that patient, sometimes I even have the patient may even tell me, listen, hey, I'm struggling with drug abuse issues. And obviously that's very helpful when they tell you that, because then, you can kind of segue and your conversation is easier that way. But sometimes, they will not tell you, but then you're talking to them and they look like they're falling asleep, they're kind of incoherent or what have you. So, it's communicating with them and letting them know, hey, listen, I noticed that you may kind of seem a little off, but, we want to take care of you. We want to make sure we get the pain taken care of, but I want to make sure that we're honest with each other. And I always tell patients, I said, listen, this is a judgment-free zone, okay? Nobody's here to judge you. For me, when a patient walks through the doors, I'm like, yay, that's awesome. Because as I said before, I didn't realize how many people hates the dentist. So when a patient actually walks into the office, I'm like, listen, we're glad you're here. We're going to take excellent care of you. How can we help you? So giving them that time to express to me how they feel, because sometimes some patients even take drugs to even walk through the doors, which is, sometimes you think, oh my gosh, and how's that possible? But yeah, some patients even just to walk in, they're sedated. And some patients, we have to sedate them to do treatment. We have to put them on something to be able to go through treatment. So communicating with them and letting them know that they can trust us, we're trained for this. That's what we're here for. It a lot of times puts them at ease.
Dr. Bensi and Chill, Dr. Grant, thank you guys so much. This was a really great session. We appreciate your time. And for all of you who are joining us this evening, thanks again for taking the time to join us. Remember to wait for the end for your CR code and the link to get your CME and your CE certification. Also, fill out your survey at the end so you can get an opportunity to win a gift card. We want to say special thank you to our panelists again, and Sophisticated Out Loud and Romance Outside the Box. We'll see you again next time. Until then, I'm Sandy Collier. Take care of yourself and each other. Good night.
On behalf of our organization, we would like to thank you for electing to take this opportunity to learn. We also would like to thank our team and panelists for helping us make this project possible. If you would like more information on T.D. Ward Jefferson Medical Society, please visit our website at tljmedicalsociety.org.